here. Okay, let's start. 1 o'clock. Everybody, welcome to the meeting. Please feel free to raise your hands if you want to make a comment or a question, or even you can, write it down in the chat. We're going to try to read any comment and bring to discussion here. I'd like to present Dr. Ana Clara Mitidieri. Ana Clara is a trauma surgeon, a digestive tract general surgeon here at Santa Casa de São Paulo. She's going to present a very interesting case for us to discuss. Thank you very much for that.
Good morning and good afternoon, everyone. I'm already apologizing for my rough English, but let's proceed with the presentation. I'm presenting a case about penetrating abdominal injuries and when tough decisions are necessary. So let me see if I can change my, okay. The learned objectives of this discussion is to discuss the approach to intraoperative hemorrhage, define strategies to explore retroperitoneal hematomas, and discuss the treatment options for vascular and pancreatic injuries. A woman of 30 years old was admitted in our hospital. A patient was brought by the pre-hospital team, victim of penetrating injuries, a knife on epigastric region, left arm and left thigh. 40 minutes before arriving, it was a house violence. The initial evaluation, she had a patent airway. The lung sounds were normal. She was using an oxygen mask, sorry. No external bleeding, cold skin. The capillary time was prolonged. She was 103 heart beatings with normal heart sounds. She had a 15 Glasgow Coma scale with reactive pupils, and she had the wound of 60 centimeters on the epigastric region with evisceration, and the other wounds were on left shoulder and left thigh, approximately 6 and 5 centimeters. Those are the locations of the wounds. This is a photo of the evisceration. What should be our next steps?
Well, let's open the discussion. Dr. Cassim.
Good morning.
Dr. Utrecht. Hey, thank you. Dr. Cassim, how are you? Good to be here.
I'm fine, thank you. Can you hear me?
Very well.
Okay. Good. According to the ATLS protocol, when you have an evisceration, patients are directly taken to the operating room without great deal of intervention in the trauma bay. But most patients, they come to the trauma bay and they get their intravenous line started. And blood drawn, registration completed. As Dr. Warren always says, that without registration, you cannot go very far. So get those preliminary steps completed, and I would take the patient straight to the operating room without any delay. That would be my approach to this particular patient. I'm suspecting many injuries: stomach, pancreas, liver, and the small bowel, large bowel. All those could be easily involved. Thank you.
Great idea. You foresee the injuries by the mechanism. Very wise. Dr. Colette, can you comment on this? Dr. Colette has shown a case in this meeting of an absolutely stable patient, and he tried to put the people inside again, suture and make a laparoscopy. Isn't that? Did you remember that,
yes.
Dr. Cassim?
Yeah.
Can you comment
yeah.
on that, Francisco?
Yes, the patient is stable. You penetration injuries by knife sometimes have around 30%. You don't have injuries in the abdomen cavity. So, if patient is stable, they need to go to the CT and show if there is some blending for other surrounds. If the knife penetration have some great vessels or some hematoma, that you have to avoid to use laparoscopy. So inside, you can put the piplon inside, close the peritoneum and make insufflation, and can see what he can exploration the cavity. But I think it's important in this patient, you have to go to make, if they stay stable, you can go to angio CT. If you don't have angio CT, you can go straight to the laparotomy. Don't avoid laparoscopy without CT to exclude great vessels injury. This patient have injuries in the arm and in the leg. There's a penetration injuries, making penetration like in abdomen, making penetrations in the arms, in the leg, in the thigh. And I need to know about the vessels of the thigh and the axillary artery and the femoral artery in the situations. Have any signs of injuries or vascular injuries of the limbs. Sometimes you have problem in these injuries in this region. You can have injuries on the vascular vessels, and then you can try to correct it. And in the left shoulder, sometimes the injuries can penetrate in the chest. Sometimes it's important to avoid to see if there is no injuries in the chest again. And in the epigastric area, you can sometimes, because it's very important, because the direction of the knife, they can come through the pericardium to the epigastrium. I have cases that we have heart injuries in the epigastrium injury, and sometimes we have a thoracoabdominal injuries, can have injuries on the left, on the right diaphragm injuries. So it's important to have an X-ray, sometimes you have ultrasound, a pericardial ultrasound to avoid injuries of the heart, and then you can go to do and other things. I think important these patients, if you're thinking about to use laparoscopy to treat, you need to go to angio CT. If you don't have, these patients have clear indications for the surgical procedure, a laparotomy initially.
Anna, can you clarify about the injury in the arm and leg and thigh? Probably a superficial ones or not?
There were superficials.
They were
They were
superficial.
not in
Let's consider
vascular,
just the abdominal one.
ways, and it's superficial.
Okay. Okay. Thank you very much. Well, let's go ahead. Continue.
May I comment?
Can we hear from Supa?
There are many comments ahead, Dr. Ultrach. You're the next one.
all right.
I will show the best. I will show the best. The best moments for you.
Okay. Thank you.
So we maintain the oxygen mask, two large venous access in the upper line. We solicited 2 packed red blood cells, O negative. Did a blood type and laboratory tests, just collect the blood. And the exploratory laparotomy was indicated.
Yeah, let's say it's the patient was considered unstable.
Yes, she was very pale.
Despite the.
And
So
that
that's the difference between this case and Dr. Collis.
The X-ray.
Sorry.
So the secondary evaluation, after receiving 500 milliliters of crystalloid, the patient was 89 heartbeat, had a blood pressure of 100/45, head and neck was okay, no stigmas of trauma in the chest, and then lung sounds were normal, in the abdomen was slightly distended, diffusely painful on palpation, with the wound that I already showed. On the spine, nothing on consideration. Upper limb abscess of deformities with the wound in the left arm that was superficial, and on the left side that was superficial, and the pulses were present and okay. The laboratory test that we received was hemoglobin of 10.5. In coagulation was normal, and in the arterial gasometer, he had a base excess of less than 7.5. So the laparotomy, when we opened, was a large amount of blood and small amount of gastric secretion. We did a temporary packing. We saw a hepatic injury in segment 4, about 2 centimeters, with no bleeding. We saw injury in the gastric wall that was anterior and posterior, about 3 centimeters, and an injury on the body of the pancreas, and a profuse venous bleeding from the rectum peritoneum, just below the pancreatic lesion. So this is where the wounds were found, in the anterior wall, posterior wall, and in the pancreas. Here in the pancreas, what are our next steps?
Can you go back on one or two slides? Now, Dr. Antrach, now we call you. There's a profuse bleeding.
Yes.
What'd you do?
Yes, certainly. So I think this was likely anticipated on arrival of the patient in the emergency room, and she was tachycardic, and so you would anticipate this. So the issue is, was it arterial or venous blood? Was it bright red or dark?
Dark, was venous.
Okay, right. So it's a zone 1 retroperitoneal hematoma that needs to be explored. Likely it's going to be the inferior vena cava in this case, because you said that the stab wound went, I guess, right-handed assailant. So the wound would have gone from from the patient's left to right as it went deep into the abdomen, then through segment 4 of the liver, then likely the retrohepatic vena cava. So need to get control of that bleeding. And so in this case, rather than trying to control the abdominal aorta, I would expose the left lobe of the liver, take down the left triangular ligament, and the left separate the base of the falciform ligament from the anterior abdominal wall, and that should allow you exposure to the inferior vena cava suprahepatically. And then you need to cauterize the duodenum and get control inferiorly to the liver, the suprarenal IVC inferiorly to the liver, and then identify the injury in the IVC. But you would have control at that point, then the anesthesiologist could catch up with further blood loss and clear away the blood in the abdomen, and then address the IVC. Likely, once you see it, you can repair the two walls, the back wall from the inside, and then the anterior wall. That would be my approach in this case.
What would be your first maneuver to expose the retroperitoneal vessels here? First maneuver.
Yeah,
like a Maddox,
well,
a Cattell, a Cocker. Would you?
No, I would go to the retrohepatic IVC the way I described to get control of the IVC, and then I would go ahead and explore the pancreas. So I would deal with the venous bleeding first by mobilizing the left lobe of the liver, taking down the falciform ligament from the anterior abdominal wall, and then doing a Coker maneuver and reflect the duodenum and head of pancreas to the patient's left.
Okay, Dr. Supa, you're the next.
But also, let me add, also have to consider looking at the drawing of the slide, injury to the portal vein as another possibility.
Dr. Supa, what you do? How'd you approach it? Would you clamp the aorta?
Besides the IVC, I think more about the SMV injury in this lady, because the injury to the pancreas is a little bit to the left, to the neck of the pancreas, and underneath the neck there'll be superior mesenteric vessels. And you said that the blood was venous bleeding, so I think more about SMV injury, or it can be other grade vessels like left renal vein or IMV or inferior mesenteric vein. But the most dangerous vessel is SMV. So in this case, I think after we enter the lesser sac and we see the bleeding, the venous bleeding, it should be compressible. So I would try to compress the venous bleeding first. I'm not gonna rush and applying a traumatic clamp to the bleeding vessel, because you can injure the SMV. And I think that the simple approach to this bleeding vessel is to transect the pancreas at the knife wound. So you do like a dividing the pancreatic neck at the cut wound, and then it would give you excellent exposure to what is bleeding underneath it. And I agree with Dr. Untrat to do the cauterization to rule out the bleeding from the IVC. And that's my thought for now. Thank you.
Let me ask you, Dr. Supan, what would be your first maneuver here? What would be, I mean, okay, let's start with the right side, moving the column to the median part, or the left side, doing a Mattox maneuver, clamping the aorta, or transecting the pancreas. What do you do first?
I would enter the lesser sac. I'm gonna lift the stomach up. I'm gonna pull the transverse colon down, and by doing that, I can see the pancreas well. And you said that the bleeding comes from just below the pancreas. I'll try to compress it first, and then I'll try to divide the pancreas up and separate the head and the body of the pancreas, and I'll go from there.
Okay. What about the next step? If you divide the pancreas, what do you do with the remaining pancreas? Would you do some kind of anastomosis, a damage control to see what you do after? Have you done this before?
The damage control, I think in this lady, she needs damage control surgery, because it's gonna be hard work, and she may lose lots of blood before we can get the control. So damage control is the first option in my opinion. So for damage control, I may just divide the pancreas, stop the bleeding, and pack, and I'll do the later stage at the second operation. And I usually, after dividing the pancreas to repair the underneath vessel, I think the safest approach is to do the distal pancreectomy with splenectomy. That would be better, because if you leave the pancreas, or even you do the anastomosis of the pancreas and you have leakage, the pancreatic juice will make the repair burst, and you will have a delayed bleeding. So that would be bad for the patient. Thank you.
Okay, that's it. Thank you very much. Thank you. Dr. Kasim, would you do the same? The approach through the pancreas, transecting the pancreas?
Let me tell you what I'm thinking and how I would approach this. This is the kind of case where you must have very clear mind, and your own computer, meaning your brain, must be working diligently for you. So I have certain rules that I have developed over the years, what I would do in a case like this. You asked others panel what they would do first. The first thing I would do here would be the mattocks. And then I will complete it with a kettle brush. Now I have a panoramic view of the retroperitoneum, including the pancreas, the back wall of the stomach, anterior wall of the stomach will be obviously visible to me. And the IVC will be visible to me very clearly. And I don't think this is an IVC injury in my opinion. I like Dr. Super mentioned, it is the confluence of the vessels behind the neck, which is splenic vein, left renal vein, and the supramesenteric vein joining together to form the portal vein. So it will be either the portal vein, intramesenteric vein, or the splenic vein. Those are the three veins will be involved because you already gave us a clue, it is a venous bleed. So I will be looking at through and through pancreatic injury with underlying vessels underneath, and I would not do any repair of the venous system behind the pancreas because literature tells me ligation is far more superior in preventing mortality than doing repairs. Ligate that. Then you are left with the pancreas. What to do with the pancreas? The dictum tells me if it is head of the pancreas, I would drain it. If it is tail of the pancreas, I would resect it. So head and tail, I have two different methods of handling in the operating room. And I would use one of those TIA stapler, transact the pancreas, take the tail out along with the splenic vessel, maybe even the spleen, and then perhaps drain the head of the pancreas in case I miss something, and close the abdomen and get out quickly, with a hope that I may have to return.
Yeah, that's the
That's
point.
my plan.
No, that's a very good one. I believe I would do the same. Dr. Clara will show you, but I'd like to ask you, any one of you that has an experience with Reboa, would Reboa be a good option here, Dr. Ultrach? No?
No, not in this case.
Try to clamp the aorta, not for this one.
No, but I wouldn't, because, when the patient came in, she was in class 1 shock because she was tachycardic, but she was a responder and her lab results were quite good. So really the Reboa is best for bleeding that's confirmed to be within the abdomen or junctional bleed exclusively in a patient who's a non-responder. So even having the Reboa, I would not use it in this case. If I thought there was a chance that in Iraq, where we have Reboa, but we have CT, but we don't have a lot of other other capabilities. If I thought that the patient could then enter profound shock at any point during the procedure, before going to the operating room, I would put a guide wire through the right femoral vein and essentially insert a femoral A line so that a Reboa can be easily inserted very quickly if the patient's condition deteriorated in the OR. But based on the data that were shown initially, there's no indication for Reboa in this case. And then when the bleeding was confirmed to be venous, I think it's better to get control directly of the venous bleeding.
Thank you. So if we have, for example, a huge bleeding during the OR, okay, you're during the operation, you kind of a lot of blood going through the retroperitoneum. Would you be a case to use Reboa or not?
Wait, was that question for me?
That's I'm asking. We are asking because we don't do this. You don't have the balloon here.
Well,
so
I mean,
it's kind of for learning.
Yes, in that case, I mean, you might be inclined to control the aorta just below the diaphragmatic hiatus with a compressor. So if you were to do that, you can more easily, if you have a femoral A line in place, in the right femoral artery, you can more quickly insert the reboa and then have the field free. So, you know, you would use it when you have an indication to get control of the aorta. So in the emergency room, you know, you wouldn't try to get control of the aorta with a thoracotomy unless the patient were moribund, but you could easily put a reboa in, you know, earlier before the patient became moribund. But basically, you'd use the same indications. But I would be, you know, we have it. It would be easy to insert when there's still a pulse palpable in the groin. So if you have it, and that's a capability that you can get, even if you don't have it, you know, a hybrid room, you know, that you have a couple around, and then they're good for several years before they need to be replaced. And you know, it's something that should be relatively easy to use in that type of a setting where where you're doing it as a precaution, having access that you can then resort to in the OR if you need to.
Okay. Dr. Ana Clara, can you proceed, please?
Yes. So intraoperative, the Matax maneuver was made without evidence of aortic lesions. Cattell's maneuver and hemostatic control of the vena cava with cardiac tape. We completed the pancreas transection to expose the retroperitoneal bleeding. During the Matax and Cattell's maneuver, there was a surgeon compressing the bleeding. We saw an injury in the splenomesenteric vein junction, about 2 centimeters, and we did a hemostatic suture, and we did the damage control with suturing the lesion in the gas scroll in a single and continuous plane, and packing and doing a periostomy, peritoneostomy. So the maneuvers. It was right here, the lesion.
Let's
right
discuss the treatment here. I'm not sure if you've got the surgeon decided to suture the vein. It was possible to suture the vein. But anyone here would ligate the vein in case of the suturing was not possible? Would you, Dr. Collet? Dr. Collet, would you ligate the superior mesenteric vein if necessary?
No.
No way.
I don't do it. No way. First, for approach this case, you have to say injuries near transection the pancreas. If you
We are
can see
recording this session.
Yes,
We are recording this session.
Yes, we have recorded the session.
We are recording this session.
Okay. Let's try to speak something. You can diminish the venous fluid, the portal vein and the mesenteric vein cross-clamping the aorta. So it's very important sometimes to cross the aorta for treat these injuries in this area. You can diminish the blending from the vena porta and vena mesenterica, and you can treat these injuries like in this situation. In this situation, sometimes I have problem to have, if I have to ligate the vein or make a suture that may be stenosis of the vein with a portal venous hypertension, portal venous that result in edema of the ball, and sometimes the patients cannot survive. So I have injuries in this situation, and I try to, sometimes it's association with pancreatitis and the postoperative, and you have problem in suture, and then if you have stenosis in the area. So I think I try to prepare the vein and avoid to ligate the vein. If it's not possible, you can have to ligate it, but you have a portal hypertension and very difficult to treat patients on the postoperative.
Thank you, Dr. Supa. Would you do the same in case of, let's say you have an injury that you got a very stenosis or a stricture of the vein that, you know, it seems not good? Would you repair it in another form, perhaps trying to take a venous patch from the saphenous vein or something like that? More complicated, more complex repairs or not?
For the SMV, I think that the best thing you can do is to do the lateral repair. Especially this is the stab wound, so it should be like clean cut wound. You should be able to do a lateral repair. Stenosis is okay by me. I think stenosis is better than occlusion or ligation, because like Dr. Cole mentioned, if you ligate this way, you would the patient would suffer from a massive bowel swelling, and that would be difficult. But anyway, if the patient is extremely unstable and the injury is unrepairable, you may have to ligate it and bail out and try to do the damage control. I have never done a complex repair for the SMV in trauma. I have never used the GSV to do the interposition graft or do the bypass, complex bypass. I think it's not practical in this situation when the patient is dying. Thank you.
Thank you. I believe Dr. Kasim made a comment here. Would you like to say something, Dr. Kasim?
The
Would you like
literature
the
tells
superior
us,
mesenteric vein if necessary?
right. I would not do any repair to the inferior mesenteric vein, and I would ligate it because the people from shock trauma have told us that repairing the inferior mesenteric vein, like Dr. Super says, is not a practical thing that they see they can do there. But having done some of these at the shock trauma, they have noticed the mortality was much higher in patients who have had some type of a repair with the interposition graft and all that, compared to just simply ligating it. But you cannot ligate the inferior mesenteric vein as well as the splenic vein, where they join to form the portal vein. You cannot ligate both of them. If you are injured in that area, then it becomes an injury to the portal vein. And again, portal vein is a very important drainage vein. You need to do something different. But doing a repair, like Dr. Super says, is not a feasible thing in many cases. And don't waste time doing that, because your mortality is going to go up in a situation like this. Having the patient wide open with the open abdomen and taking a long time for this. Get out quickly, ligate and get out.
Thank you. Dr. Utrash raised your hand?
Yeah.
Or not?
Yes,
Yeah.
Dr. Ginsburg has pointed out previously that long term you can't leave a patient with a ligated superior mesenteric vein because for the reasons that Dr. Supa and Dr. Pillay mentioned. I think in an emergency you might have to do that for damage control, but left that way, you get the bowel swelling. And there was also another case, I believe, presented where that was in fact done in a young patient, and he suffered a very severe case of short bowel syndrome. So it's very difficult post-operative course where they were considering, or I think he was put on the list for intestinal transplant. So depending on this, if the patient's going to die otherwise, I can see how you'd have no choice. But certainly if it can be easily repaired, a lateral repair with a suture, like Dr. Supa said, based on all the cases that are presented here, I would take that approach. Years ago, I might have been tempted to do a ligation just to stop the bleeding, but the consequences can be pretty dire. So you can be in a bad situation if you do, bad situation if you don't. So it's a really delicate judgment call.
Thank you. Can you proceed, Anna?
Okay. So that's the peritoneostomy. The the volumetric balance in the intraoperative, the patient received the first 2 packs of red blood cells in the ER, and then received in the operative room 7 units of packed red blood cells, 5 units of fresh plasma, 6 units of platelets, 1 gram of transamine, 2,500 milliliters of crystalloid. The bleeding was estimated in 3 milliliters, 3.5 milliliters, and had only 100 milliliters of diuresis. In the post-operative, those are the laboratory tests. The hemoglobin was 10.3, and the base excess was minus 2.3.
You go ahead.
Okay, so the patient was sent to the intensive care unit with oxygen supply, heating, and treatment of the coagulopathy and bleeding surveillance. She evaluated with norepinephrine of 0.4 microgram kilos minute and vasopressin with oral tracheal intubation with a good fraction of oxygen and fraction of oxygen. On coagulation, she had a RNI of 1.8. She had a fever of 37.8. The renal function was stable, and we controlled the pressure, intra-abdominal pressure. And she had a reapproached about 5 to 2 hours after the end of the initial operation. So in the
Okay, so we had the pancreas. Let me ask them, and what do they do with the pancreas? Dr. Supa was, I'm not sure who made the comment, but they were Dr. Supa or Dr. Kasim said, well, let's do a pancreatectomy, a distal pancreatectomy for that. Would we have any other option for this pancreatectomy, Dr. Supa? Let me see. I don't want to forget anything. Dr. Supa.
I think, like I mentioned, I think the safest approach for second operation in this lady is to do the resection of the pancreas, distal pancreatectomy and splenectomy, because it would leave your
Splenectomy too?
safer. Yeah, but anyway, if you really want to save the pancreatic tissue, you can try to do the pancreaticojejunostomy, anastomosis using a Roux-en-Y. But it would not be easy in this lady, and it could result in bad complications. So I think the safest approach is still distal pancreatectomy. Thank you.
Thank you. Dr. Otrach.
Yeah, so I agree that it's probably not the time to do a Roux-en-Y pancreaticojejunostomy, but at the re-exploration, if the bleeding is under control, everything looks good, I would, in fact, I would have tried to do this at the initial operation, put a catheter through the neck and the neck body and toward the tail of the pancreas, and then place some drains, which I don't recall that you did that at the first operation, putting drains, but I would be sure it's widely drained, and try and oversew the distal portion of the duct, that portion that cut across that goes into the neck and the head of the pancreas, oversew that, and incorporate that area with the drainage, make certain that the repair of the venous injury is holding and is good, and that there's good flow through the SMV, that the bowel is not edematous. And I gather, or I guess you, in the operating room, did I miss the findings? I guess you didn't give us the findings of the second operation, but make sure that the bowel is not swelling and that there's good venous drainage of the intestinal tract. But I would not
Cool.
just do the best to keep the patients, allow the patient to recover, and then come back a few days later when she's physiologically in good shape, and then do the drainage of the distal pancreas, or do the distal pancreatectomy and splenectomy, the third operation.
Which one of these two would you prefer? The pancreatectomy or any kind of who and why pancreatic jejunostomy?
At this operation, so 52 hours later, I would not do either. I would continue with the damage control, make certain that the distal pancreas is adequate, that the duct is adequately drained. You can put a catheter in it, put some good sump drains in the area, try to oversow the proximal portion of the resection, the incision into the pancreas, and then make sure that the small bowel is okay, that the venous repair is good, and that there's no bleeding, and then get out and let her recover from the physiological insult before doing anything more major.
Okay, thank you. Dr. Collet, any other ideas? Go to the pancreatectomy or any other surgical approach?
Gustavo, if you have transection the pancreas, you have transection the visceral duct. So in this situation, you have to resect the pancreas, distal portion of the pancreas, without or without splenectomy. I think in these situations, the pancreas is transected. So you have 52 hours later, you have some pancreatic fluid in the peritoneum, you have some problems in the situation. It's very difficult to make anastomosis on the pancreas, and you know that the pancreas jejunal anastomosis in this situation is not very do well. So in these situations, I take this patient to the OR, I take the distal portion of the pancreas and make a drainage of the peritoneal area. I have some comments. I'm missing to tell that sometimes you have injuries of the vein. You can put a temporary shunt in the vena porta, and then later you can go and make a graft, a saphenous graft in the portal vein injuries to treat. It's possible, it's not very difficult to imagine it, and it can make damage control more quickly than try to fix the vein. So it's very important to know that you have sometimes to put a venous temporary shunt in this situation. And important, you don't have to go to make in these situations, you have avoid Whipple surgery. So there's not indication Whipple surgery in this situation. You have the distal portion of the pancreas you can take and preserve the head of the pancreas. So I think the most important thing is this. If you have all injuries in the pancreas, you don't transection the pancreas, you can put a drain and observe. But if you have transection, the duct, you can have to make more aggressive to avoid complication.
Okay, can go ahead, Anna. Go to the end.
So in this new approach, the intestinal hooks were viable with no edema and without other lesions. We had necrotic fat tissues in the mesentery and the transverse colon, compatible with the pancreatic fistula. The stomach was open in the anterior wall lesion, but the posterior wall was sutured, and the pancreas was sectioned about 2 centimeters after the cervix with the presence of necrotic tissues. It was possible to highlight the 2 holes of the pancreatic duct, and the vascular suture was intact in the superior mesenteric vein without bleeding, with area of stenosis in the splenomesenteric junction, without signs of thrombosis, and the spleen was viable. There is a little video here that the 2 holes of the version was put a tube, and in this photo that you can see. So we already discussed about the remaining pancreas. So the approach was that we sutured the lesions in the anterior wall of the stomach and did a projective muscular over suture in the posterior wall. We did a pancreatectomy of body and tail from medial to lateral, preservation the spleen, catheterization of the remaining pancreatic duct with subsequent suture of the orifice, and invagination of the parenchyma. We passed a nasointero tube positioning the jejunum and extensive drainage of the remaining pancreas with silicone drains, and we closed the abdomen, the upper nostril skin. We have here another video. You can see here in the photo is more clear to see our structures.
This the pancreas had been resected already. Yes. Okay.
So
okay.
there was an operative time of 3 hours and 50 minutes. The patient received 1,075 milliliters crystalloid and 1 packet of red blood cells through units of fresh plasma, had a bleeding of 600 milliliters and a diuresis of 600. Postoperative, she had a hemoglobin of 10.8 with arterial gas testing with okay, with a lactate of 3.9, and she was referred to the intensive care bed under autotracheal intubation using a small amount of noradrenaline. Can I continue?
You can do well. You can summarize the next steps to the end of the case, so we have more 10 minutes to comment.
Okay. In the third day of postoperative, the patient was without drugs. On the fifth day, she was extubation. On the seventh day, we saw that she had a fistula and had to change the antibiotics. She had a CT showing thrombosis of the mesenteric superior vein. So we entered with enoxaparin. On the PO 12, she was receiving enteral nutrition. And the next day, we already entered oral nutrition.
Anna, when you diagnose, let me ask you, when you diagnose the thrombosis of the superior mesenteric vein and you anticoagulate the patient, how was his abdomen? Would you notice, bad evolution or distension, or how was he?
She was in feasting yet, so just receiving parenteral nutrition. We did the CT scan because we suspect that this could be could happen. So we did a CT just to diagnose.
Okay, let's go ahead.
She
So that's the point here for us to discuss. We had a suture, we had the stricture.
Yes.
Go on.
So she evaluated with high blood sugar, necessitating insulin. But after we took out the enteral diet, she was okay with no necessity of insulin anymore. She evaluated with fungus infection on the PO 26 with we had to put fluconazole, and on the 29th day we removed the abdominal drain, and on 53 days of post-operative, she was discharged from the hospital, and she evaluated with Clostridium infection after that we could treat it with oral metronidazole. And we know that the patient, this case happened 3 years ago, and we received information that the patient it's okay, still using rivaroxaban and without any complications last year.
Thank you very much. What a case. I'd like to ask our panelists for your final comments, please. Let's start with Dr. Ultrach.
Yeah, well, beautifully handled, and kudos to the other doctors that diagnosed location or presumed correctly the location of the bleeding. And if I understood correctly, you put a catheter in the pancreatic duct in the head of the pancreas to create a controlled fistula, if I understand correctly. And then what did you do with that catheter? That was eventually pulled out like one of the drains?
No, we
It's
only
just
put it
during the
to
operation.
find the orifice. So we
Sutured and then took the tube out. So the fistula was created by the drains. It was a controlled fistula. You were able to take the drains out, and it resolved. So that was very nicely handled. And then, have you done any follow-up studies to determine if the superior mesenteric vein and portal vein have opened up and there's good venous flow now to portal venous flow?
The patient, it's she's receiving accompaniment. She's been following
with the vascular surgery team. Yeah.
Yes.
The vascular surgery team with us. They kind of make the follow-up with CAT scans, and they still giving her about 1 year ago, Anna. You said 1 year ago?
Yes.
About 1 year ago, they still had, she's under rivaroxaban. Yeah. Yeah.
Yeah. Well, nicely handled. Excellent case.
Thank you very much. Now, Dr. Supa. Dr. Collet? I'm sorry, Supa first, then Collet.
To repair this injury, I think it's very, very difficult, and it's much easier said than done. And you did a wonderful job, and I learned a lot from the real patient. Thank you very much for presenting this case.
Thank you.
Dr. Collet?
Yes, thank you for the presentation. This case is very interesting and sometimes very difficult to treat injuries in this area, and how to treat mesenterica, superior mesenterica vein, and portal vein is very difficult to approach. Thank you for the presentation and for the explanation for the case.
Thank you. Dr. Kassim, final comments?
Well, this case takes me back, way back when I was a chief resident at Vancouver General Hospital. I had exactly the similar case at that time, and I did what Anna did then. That was more than 40 years ago, 35 years ago. And it was a long haul. I think the patient was in the hospital for almost 3 months, and went through a lot of complication like Anna's patient has gone through. And from then on, I kept looking for wisdom from other surgeons, what they would do. So what I have learned in the ensuing 30-year period, that At the index operation, which is the initial operation, there is no room for Whipple procedures such as pancreatectomy. They taught me you drain the head, you resect the tail, and get out as quickly as possible. And then make sure that you return the patient back to the operating room at subsequent time to evaluate what you need to be doing. And be prepared to have complications of the vessels underneath the pancreas, i.e. The mesenteric vein, the portal vein, the splenic vein. Any of these will get thrombosed, and you need to be aware of that. And then on top of that, collection, abscess formation, are all very common after something like this. Like Dr. Supra says, this is not an easy task. This is not for the faint heart and the novice. And you need a lot of help. You need to have several surgeons involved, and they all have something to contribute for the well-being of the patient. And I think your surgical team did a fantastic job in saving a life of this patient. Let me tell you what happened to that patient that I took care of 30 years ago. And when she came to the outpatient clinic, when she saw me, you know what she did? She slapped me. She gave me a big slap and she said, "You left me with a big hernia." And she was not grateful at all for saving the life. But of course, you know, post-op hernia is very common in cases like this. And I never forget that. Thank you. Thank you for enlightening me again with this case. There are a lot of pearls in this case that I have learned. And I shall remember this. Thank you.
Thank you.
You're welcome. You're welcome, everybody. Thank you very much for your comments. Dr. Anna, thank you very much for preparing the case. Again, congratulate you and the team for this spectacular result. Deciding to transect the pancreas is for an experienced surgeon, and this must be done early in the surgery to control the bleeding. So congratulate you and your team for this result. And I'd like to congratulate everybody here for being here. I'm Dr. Supa, Dr. Kasim, Kole, and Dr. Utrat for being our panelists and teaching us their experience, sharing their experience. Thank you very much for that. Dr. Antonio Martos would like to come in and finalize the meeting or not?
Yes. Yes, I'd like to say thank you very much, Gustavo, for leading this meeting through Spite. It's just an honor to have such good case coming from Latin America, from the world, and now from Brazil as well. Amazing discussion. To see is a tough case everywhere in the globe, and just showing that trauma surgery is a very difficult specialty, and experience matters. Thank you very much for the case. Super looking forward for another case from you. Has been some time, so looking forward for a case from Thailand the next few weeks, please. And I'd like to say also thank you very much for Kevin Miller for managing this meeting. I know technical side, backstage is sometimes very challenging for managing this meeting, and has been great. Kevin, thank you very much for coordinating this meeting. Okay.
Thank you.
Thank you all. See you next week. Next week, you're gonna be the meeting with WST, and we are looking forward to seeing everybody again. Thank you all.
Thank you all.
Thank
See you
you.
there.